business process management and case management. U.S. healthcare needs you. I should mention about 4 years ago I came to a process.gov, which was run by Keith Swenson. It was about business process management, adaptive case management, and I remember I introduced myself as an emissary. You know, we think of an emissary, you think of emissaries from other planets, from other empires. I was an emissary from health IT to the workflow technology community. And so it's been very interesting over the last 4 years to see the evolution of conversation and in some cases diffusion of technology, the creation of success stories using business process management and case management, adaptive, dynamic, and so forth in healthcare. So I'm kind of excited here to talk about how to basically sell more workflow technology in healthcare. I'm a pre-med accounting major, only one I ever met. So there's cost. Master's in industrial engineering, workflow, usability, human factors, artificial intelligence, master's, knowledge representation, planning, natural language processing, and then of course medicine, the domain. And that HC BPM stands for Healthcare Business Process Management. And when you got a bunch of degrees like myself, and my mother says I'm killing myself by degree, you look for the intersection. And the intersection I've found over the years, and I was a chief medical informatics officer for an electronic health record vendor for over a decade, is healthcare business process management. And that's what I'm here to talk about. 20 years ago, when I was interested in both health information technology and workflow technology, both communities were sleepy little hamlets. And it wasn't even called BPM back then. But today, we have Washington, D.C. down here, we have Baltimore up there, and we've got this metroplex. It's still shaped like a dumbbell, but in between there, that is the Washington-Baltimore Parkway. It's very busy, which I took a picture out my window one time. So I'm adding that. And just think, in another 25 years, that'll all just be one big metropolitan place. But I'm interested in accelerating that. I really want to turn health IT and workflow technology, BPM, adaptive case management, into one big hybrid amalgam of exciting interactions with no little conduit through which things have to travel. And so, what are the top 10 obstacles to selling workflow technology into healthcare and to health IT folks? Number one is workflow complexity. Simple data and complicated workflow is complicated. Complicated data and simple workflow is complicated. Complicated data and complicated workflow is hyper complicated. And that's this messy spaghetti symbol. In fact, a fellow named Will Vanderwalst, who's one of the top academic experts on business process management, he's written over 200 papers and chapters on workflow technology and the theory behind it. He's also published about 20 or 30 papers on healthcare, and he calls healthcare processes spaghetti processes. They are so complicated. About 15, 20 years ago, health IT tackled data. It basically represents multimedia, data models, all those tables in those electronic health records are modeling the 206 bones in the body and the zillions of drugs. And it basically made the users the workflow engine. It just said, we'll just let the users do all that automated workflow. In fact, I looked at a 200-page manual for an electronic health record, and 180 pages were about workflow, and it was all about what to click on next. It wasn't about how the workflow engine worked or how to create a process definition. None of that. No cost competition. Why would one want to implement workflow technology in order to become more efficient if you are paid whatever it costs you plus 5%? So you're paid according to volume. Now we're moving to a more of a value-oriented situation where accountable care organizations are being assigned the goal of taking care of a set of folks in a population, and they're responsible for both the clinical outcomes and managing the costs. And the more efficient and effective they are, the better they do. The more profit they make, or the more money they can reinvest into their operations. So this is an example of two obstacles that were there and are receding. So for example, we've hit a workflow wall in health IT, and people are starting to realize that. The regulatory environment. When you got a lot of red tape, it's hard to be innovative. In particular, a few years ago, the government said, we'll give tens of billions of dollars to subsidize electronic health records and related health IT systems. So a hospital could get $2 million plus if they purchased a certified electronic health record. Physicians could get tens of thousands of dollars per physician for purchasing a certified electronic health record. If you look at that certification, the list of things you have to do, none of them are about efficient workflow. They're all about things you have to check off. Did you ask about smoking history? Multiply by 200. But that money is starting, the majority of that has been spent. And so it's less of a lever. And there's also kind of folks are kind of a backlash. People are saying, wait a minute, this is slowing me down. Screens versus workflow. A pretty computer screen is easier to sell in a glossy health IT magazine than some abstract notion of some sequence of tasks that you can easily adapt to fit the way you practice medicine. Threat to revenue streams. If you're a hospital and you're investing in health information technology and electronic health records, you have a mandate from your president or CEO to get certified, to get that certified technology in there so you can get that $2 million check. And there's no air left in the room for experimenting, trying anything innovative. And the irony is, more and more CIOs of hospitals are from other industries. They're familiar with workflow technology, but if you talk to them about this, they say, I know, but we're sort of stuck with this situation where we have to do X, Y, Z in order to get that subsidy. Long word, skeuomorphism. When you read a book on the iPad, you know how the pages look like they're flipping, and the books are like on this wooden bookshelf? So taking the physical world and kind of re-representing it on the computer screen is what usability engineers and cognitive psychologists call skeuomorphism. And I know I don't know what the Latin or Greek root of that is. Here we have a complicated medical form. And many of the early electronic health records look just like this, except that all these little areas here were places you could type. Now they don't look quite as much like that, but essentially there's just a whole lot of places to click. In a workflow system, you would chop that up into 4 or 5 pieces, and you would present it to the right person at the right time. So it'd be less cognitive effort to fill it out. But what's happening there is with the popularity of iPads and Google Glass, where the forms are getting smaller, you can't cram all that onto the forms. You have to chop it up and then sequence it in a natural workflow. Workflow stereotypes. It was true perhaps at one time that workflow engines kind of just told people what to do. Think of being the bowels of some bank. But in fact, as you know, with all of the debate about adaptive and dynamic case management and so forth, that these systems are more and more about doing for you so you can be freed up to do something more valuable. Okay? And if someone doesn't want to do it, they can jump off the happy path, and it will remind them later according to whatever rule. And many medical errors actually occur because you're interrupted. So workflow technology is relevant to patient safety. Here we have the not invented here syndrome, and that is entire computer languages, databases, and operating systems have been invented by doctors. And guess what? They're not as good as computer languages and databases and operating systems that were invented by computer scientists. And yet, the two most successful electronic health records, Vista, open source electronic health record, and Epic, which I think I've heard 30 or 40% of folks are in, their data is in hospitals that use Epic, both use Monks, which was a language developed by, most charitably put, health IT professionals. Billing emphases. Now, in the back there, you see those things that look like bills. Well, those are like forms. A lot of electronic health records evolved from practice management systems that were intended to generate messages that could be sent, or paper, or printed out and sent to the payer, okay? Or reports that were to be sent to the government. And everything was done to make sure that the lowest possible probability that would be rejected would occur, okay? They weren't designed starting with the user and what they were trying to accomplish. They weren't designed to help the users do their jobs. But you can see, as we make this transition from volume-oriented to value-oriented, the old systems that are based on maximizing revenue are going to have to be replaced by systems that maximize efficiency and effectiveness. Finally, paradigm shift. Thomas Kuhn was a philosopher of science, and he said, do you ever notice how you have to wait for a generation of scientists to retire or die off before the new set of theories can kind of take root? And health IT wedded itself to structured documents 10, 15, 20 years ago. It takes that form that I showed you, takes it apart, maps it onto relational tables, and basically the data model, the data schema, is the user interface. And yeah, it sucks to enter data or to enter orders into that. But a structured workflow platform it's like turning the world on its head. I think of the British bands playing, the world turned upside down. So it takes a mental leap to understand there's a different way of managing information. When I talk to health IT folks and to doctors, and a lot of physicians are starting to become almost like chief information officers. We call them chief medical informatics officers. I show them a slide like this, and I call it the power of process. And in the executable there, with the asterisk and the models in the asterisk, I'll explain in a moment. And instead of talking about workflow engines, I used to have a really funky looking Corvette engine. All those pistons going. I replaced them with a cute robot. That's the workflow engine. It can execute various models of work. And when I say a model of work, I don't just mean the traditional workflow diagram. A model of work could be goals and the relationship between the goals and various sort of rules of inference for reasoning about them. I put the create in there because increasingly you can use workflow analytics, that data exhaust, to feed that back in to improve throughput and to improve the probability the output will make someone happy or achieve some goal. Over here on the right, we have the human who can create, if they're a clinical analyst, or at least understand, look over the shoulder if they're a practicing physician. And so this layer of abstraction in between is a more appropriate and more natural and more productive means of communication between the computer or the technologist and the clinical analyst and the clinician. And over here on the top that's kind of a traditional workflow diagram. That sort of pick listy thing on the right is more of a kind of a case management. Here's a set of tasks, can be done in any order. What percentage have you And so the asterisk just has to do with, I'm acknowledging that you guys have a very healthy debate, which I love to listen to, about the whole structured versus unstructured, various kinds of notations dealing with predictable versus unpredictable workflows. And both of those happen in healthcare. Kurt Lewin had this thing he called a force field analysis. And he said, if you're trying to figure out whether a big complex system or a society is going to change, you have a set of things that are lined up that are resisting change, and then you have a set of things that are trying to cause change. And on the right here, we have the 10 things that are the obstacles. And I'm not going to go too much into each of these, except to say all of these are weakening. They're weakening for various reasons. The subsidies from the government for certified EHRs, a majority of that has been paid. People are more sophisticated about understanding the importance of workflow. As people start to use various kinds of mobile platforms, you can't fit all those crazy forms on that little thing, so you've got to come up with other ways of interacting with it. And I'll say paradigm shift. It's just the current paradigm has run out of steam. And so, for example, there are thought leaders who say the biggest problem in digitizing healthcare is usability. And then you have the Health Information Management Systems Society, which is the top sort of lobbyist and vendor association, and they say the number one usability pain point is workflow. And then when you talk to them about they say they don't know exactly what they mean when they say workflow. Now, when I talk to you guys, I used to give 10 years ago, I gave presentations about workflow technology, and I would get someone from the business process management industry who'd wandered into health IT, and they said, I've been to a zillion presentations here, and you're the only one that's talking about workflow, the same way you keep the workflow professionals that I work with talk about workflow. But there are more and more folks in health IT that are absorbing ideas and beginning to adopt business process management and adaptive and dynamic case management technology. Now, that was the first half of my presentation. And what I want to talk about now is, what is it that can be built? And by what route can it be driven to chase after these receding, weakening forces and just push them off the edge of the screen? About a couple months ago, there was a healthcare business intelligence conference here in DC. I tweet a lot, do a lot of blogging, and this was a picture I tweeted, and it says, to be an accountable care organization, and that's that organization that's responsible for taking care of a set of people, a population, basically managing their clinical outcomes and their costs, and being responsible, and the more efficient and effective it is, it gets to keep the difference. I'm going to talk about IT systems. What are the IT systems that are necessary to build an ACO? And I'm going to give you 2 or 3 different takes on it. And in this case, the expert said you need 3 things. You need a common electronic health record. So that's the data about the patient. And when I say common, you might have more than one, but then they got to be interoperable. It's because you've got to be able to pull that data out to improve outcomes and reduce the cost. You need a data warehouse. You need a way of taking that data if you have more than one system and putting it into some format that you can mine, generate reports, explore, use changes in that to trigger things that happen, actionable things, things that intervene and improve health, to improve the overall aggregate of the health of that population. And then you need a care coordination platform. I truncated it here, but on the tweet I said, in parentheses, that care coordination platform should be a workflow platform. That is what you need to build it on. And you see like 13 people retweeted it. And these are health IT people. So there's a kind of we see coordination technology, workflow technology. I think it's important because a lot of you are IT people, to actually sort of say, well, what are the systems that go into creating an ACO? Well, this is my set of categories here. that are kind of synthesized from a bunch of places. We've got assessments and onboarding. So you've got to like get the people who aren't in the population, who deserve to be in the population. Once they're in the population, you got to get them involved. Going, if they have a chronic disease, they need to be in management of it. Outreach and engagement. You need to know, do they respond to texts or phone calls? Or does someone go to knock on their door? You've got the actual care planning and delivery. Look at surveillance and intervention. All this stuff is happening, and you're looking at and you're watching. What are the trends? Are we doing good? Are we doing bad? At the end of the year, are we going to make money? We don't lose money. We've got all that data analytics, looking for patterns. And then finally, all the management reporting necessary to say, this is the result, the government, please pay us, or these are what we've done, insurance, please pay us. Each of those 6 areas has about 6 or 7 subsystems, okay? And some of you are already doing some of this. You may already have a healthcare partner, which has been doing one of these. Fantastic. You may be doing something similar, but not in healthcare. Or some of this is clinically oriented, and you're new to healthcare. And so this is a form of desensitization. You haven't heard of it before? Well, now you have. And you can just think of this as a poem. Okay, I'm going to read all those in order quickly. And so if one of those, or 2 or 3 of those lines causes a synapse to fire, that's great. By the way, all these slides are online on my blog for commenting. And in fact, during the conference, I've been tweeting them out. Anybody on Twitter probably has seen them go by. Okay. Member identification, enrollment, risk and clinical assessment, behavioral screening, cultural screening, family and caregiver support, advocacy, beneficiary protections and coordination, clinician outreach, education, member outreach, reminders, health homes, multidisciplinary care teams, evidence-based care guidelines, post-discharge transitions, medication reconciliation, therapy management, referrals and scheduling, service coordinators, navigators, and concierge services, medical management, clinical decision support, remote patient monitoring, telehealth, transportation, data collection, electronic health record integration with a health information exchange. You've got to get that data moving around. Medical terminology management, patient member segmentation, longitudinal patient view, data warehouse and reporting. Only 6 more. Care team management, home visit management, quality and outcomes measurements, compliance and adherence reporting, coordination of benefits, and financial and reimbursement management. Thank you very much for letting me do that. If a couple of those sounded like, hey, wait a minute, I do that, great. Or if some of them you hadn't heard before, at least you've heard of them. But those are sort of some of the pieces that make up an ACO. So as you come into healthcare, what are the hot button topics? What's on the kind of topmost in folks' mind right now that are relevant to workflow? Last week, I did a 5-part blog series. The top health IT blogger went on vacation, and he said, Chuck, you can take over my blog. Okay? And I don't know what the traffic is, but it's the #1 health IT traffic blog. And so I wrote 5 blog posts. Number 1 was Workflow 101, which I'm not going to go over here. But these are the next 4. Interoperability, usability, patient safety, population health management. I have a slide per. Interoperability. Will Vanderholt, so I already mentioned, top BPM researcher in the Netherlands. He calls BPM the spider in the web. When he says spider in the web, he means the business process management with all its adapters and the flexibility of the workflow representations and the way the engines can be monitor things and make things happen automatically can be a kind of glue between disparate technologies and disparate systems. And healthcare is full of disparate technologies and disparate systems that need to be glued together to create the ACO. A major focus in healthcare has been on syntactic and semantic interoperability. By syntactic, there are like little characters, pipes and hats, HL7, and they allow you to get the message from one system to another, from the pharmacy to from the practice to the pharmacy, or from the hospital to the practice. Semantic interop is there are all these codes, all these alphanumeric codes, and they stand for drugs, or diseases or procedures, and you send them to the payer to get paid, does that code mean the same thing in both systems? It's semantic interoperability. You never hear about what the academicians call pragmatic interoperability. Pragmatics is also from linguistics, just like syntax and semantics. Pragmatics means using language to achieve goals. Can you pass the salt? Literally, you would say yes, but that would not achieve my goal. I also call it workflow interoperability. And workflow interoperability is the degree to which the message effect matches your intended effect. That is, when I send a message from this organization to that organization, I send it for a reason. Does it achieve that goal? So if I'm a primary care practice and I send a referral to a subspecialist and I don't hear anything back, after a while you want to say, hey, did you get it? Do you still have it? Are you still working on it? What's the status? Or you get it back and it doesn't make any sense in the context. Why am I getting a lab result here? I'm expecting an image. And so there's a conversation that has to happen between systems to clarify, to check assumptions, to catch things from falling between the gaps. And workflow technology is really good at that, but syntactic and semantic is really a tactical level. So you can kind of compensate somewhat by gluing these systems together, and at the workflow level saying, wait a minute, does this match what I expected? And close the loop. Workflow usability is a big, enormous problem in healthcare. First of all, there's way too much manual workflow. People clicking. Doctors bitch about this. That's because the users are the workflow engines. There is no workflow engine to save them time. And when the workflow is automated, it's automated using Java, C#, mumps, if-then statements, case statements, switch statements. It's hard-coded in third-generation language. You have to go and change the code, which causes errors. They got to redeploy. So it's not customizable in ways that you guys take for granted. The code is transparent. You can't see the design workflow. And when the workflow is executed, you can't see at a glance what is the state of every task. These systems are relatively opaque because they're not workflow management systems. They're not BPM systems. They're not case management systems. So business process management and case management do out of the box exactly what the health IT systems do lousy if they do it at all. Patient safety and task support. There have been horrendous headlines about mistakes made. Some bit of information was sent from one place to another, or it just disappeared into the void and never got followed up. And invariably, these are workflow related. So there was some handoff that didn't hand off. Or someone was doing something, they were interrupted, and then they never came back to finish it. Whereas in a workflow system, you've got models of workflow. You have tasks. And if the task languishes after a while, you can remind someone. And then you have clinical decision support. Well, you're on this drug and you're on this drug, and those interact in a bad way. Good. The problem is these clinical decision support systems are unintelligent. They are not context aware. They're not aware of the workflow. And so you get a zillion alerts, and you get alert fatigue. And doctors just ignore them or turn them off. And so whereas business process management has this history of combining in its suites such things as business rule management systems and workflow and business process management systems. So there's opportunity there to more seamlessly combine decision support in a practical day-to-day workflow. And so those are those unique strengths that I referred to. Population health management. I looked at about 2 or 3 dozen definitions, and this is the one I came up with. It's a synthesis. Proactive management of clinical and financial risks of a defined patient group to improve clinical outcomes and reduce cost via targeted, coordinated engagement of providers and patients across all care settings. Well, think about SMACs, social mobile analytics and cloud. There's obvious relevance. Social, the patient, wherever they are. Mobile, out and about. physician too. Analytics, relevant to improving outcomes and reducing costs. And then across all care settings, cloud. You've got to do something in a virtual way. But what I want to focus on is targeted and coordinated. Targeted means you need to find the patients at risk and intervene quickly enough to be of benefit. That's complex event processing. So you have patients who are not enrolled in a chronic management program but should. They're enrolled but they're not measuring the right things that they should. Or those numbers, glucose level, is out of bounds. Okay? So you could have someone who is perfectly healthy and then all of a sudden they need to be admitted to a chronic management program. You could be in a chronic management program, the numbers are being measured on the right schedule, but then they move out. So a change in the patient's status needs to trigger a workflow to intervene and stop that trend, that bad trend. Coordinated. Once you kick off that workflow, that's the automated workflow that you don't want to be extra workload for someone. You want it to be transparent. If a task languishes someplace, you want to be able to have it pop up and say, hey, wait a minute, what about me? So there's this great fit between the complex event processing and the business process management, which is a fit that other people in BPM and other industries have noted. That's very relevant to healthcare. A couple of tweets, and I guess they're sort of an advertisement. If you're on Twitter, I'm Wareflow, Wareflo. I'm sort of Dr. Workflow. And I've got about 4,000 or 5,000 health IT people, and I tweet about workflow. I tweet about this stuff. So the difference is 90% of the time I'm talking about workflow to health IT people. In your case, I'm talking to workflow technology people about how to talk to or how to understand or deal with the health IT people. So it's meta marketing. So there was this article, which I really liked. And the author said, population health management is going to require combining, integrating all of these systems and more. Electronic health record, health information exchange, analytics of risks, care management, revenue cycle management, supply chain, cost accounting. That's the BPM spider in the web, gluing disparate technologies and systems together. But then look at this next tweet. Don Fluckinger is a health IT journalist and an expert on population health management, said, population health management boils down to lists, actionable lists. Well, what does BPM and workflow management systems do really, really well? They do well at putting the right item in the right work list for the right person at the right time. And so you've got this style of processing, what academicians call process-aware information systems, which sort of encompasses BPM, workflow management systems, certain styles of case management systems. And it can glue together all the systems that need to be glued together. And it can provide a user interface that is parsimonious and relevant to improving the health of the population. One more wall of words. I think this is the most important slide, so I'm going to read it out loud, just like the other one. I've looked at lots of population health management systems. There are startups, there are big health systems that are just building their own systems. If you drill down in almost every sophisticated population health management marketecture, and a marketecture is a bunch of boxes and arrows that shows you the structure of some complicated information systems that can be communicated to some stakeholders. You will see, if you drill down far enough, you will find business process management and case management ideas, and increasingly actual BPM and case management platforms. There may be some folks here who are actually involved in that. Now, the interesting thing is the health IT people aren't always that excited about blowing the horn of the BPM vendor. So often they will rebrand this as care management or healthcare process management. But there's also a knowledge that the BPM and the workflow management industry, which has been around for years and is growing, The health IT industry is a large industry, about 10 times larger than the workflow technology industry. It's growing about 7-8% a year globally. But the workflow technology industry is growing at about 2 or 3 times the rate. Okay, so there's a lot of cachet. And so it's hard to not try to leverage some of that if you incorporate, let's say, a pure play BPM vendor into your ECM solution. Okay, so what is to be done? This is about marketing, meta marketing. So how do we just go running after those 10 things that are opposing workflow technology and just drive them from the field of combat? We need to continue to educate users and buyers so that they can recognize flexible, transparent, improvable workflow. We need to leverage success stories, and I've got a bunch of websites. I've got about 500,000 words out there on various websites about this stuff, and one of them is just links. There's almost 2,000 links to, on one hand, health IT workflow problems and horror stories, and on the other hand, business process management, case management successes. There's just such a great fit between all the problems of all the sterling qualities that traffic jam between DC and Baltimore is going to get worse, and I want it to, but not literally. Okay, now one thing I've seen is that the BPM and case management folks are sometimes partnering with health IT people who know the clinical content and know the workflows and know the customer's pain points, and they're realizing the light bulb is going off over the head that they've got to deliver some kind of transparent, automated, flexible workflow solution, somehow integrated with their own solutions. I'm seeing more of those kinds of partnerships. Join the health IT social media workflow conversation, and it actually exists because I've spent a lot of time and investment making it exist, blogging and tweeting. I've got about 4,000 or 5,000 folks who follow me, and I'm basically, it's like just like this, except it's to the health IT people. Foot in the door and pivot. I've seen this. So the health IT partner and the BPM folks will put something together, they'll install it, and the customer will go and they will look under the hood and they say, wow, there's this workflow engine under here, and I can like diagram all kinds of models of work. What else can we do with this? So you're pivoting from one of those 50 things I read to something else. Now, as a physician, I want to see this stuff go all the way to the point of care. But I understand that there's a lot of stuff, human resources, payers, so forth, that's kind of back office. And it's sort of similar to what's already happening in the other industries. And that's a kind of a natural entree for this kind of technology to come into healthcare, and then people who have a foot in human resources and a foot on some clinically relevant area, and they'll say, wait a minute, can we use this over here? One more thing. I've heard people say that, this is classic business process management. It's all rigid, it's repetitive, it's structured. We've automated all of that, and that's why we have to do the knowledge work and the unstructured stuff. Guess what? In healthcare, hasn't even automated the structured, repeated, boring stuff yet. And that's why you have all that manual clicking going on. Yet, healthcare has even more unstructured workflow than other industries, both relatively and absolutely. It's a $3 trillion industry. Will Van der Waals estimates that the U.S. healthcare economy could save between $600 and $800 billion if it universally adopted process-aware information technology, BPM, process mining, case management, place where you're modeling goals and so forth. So healthcare needs both business process management and case management, and that's a good thing. Traditional health information technology has hit a workflow wall. It is constructed from invisible, inflexible, and inefficient workflow and really, really unhappy users. And there's a window of opportunity in that wall that consists of business process management, adaptive case management, process-aware information systems, more broadly construed. Healthcare process management, care process management, which is sort of a rebranding, you see, because, well, maybe the doctors don't want to hear the word business, which isn't necessarily true. So again, we have this merging metroplex. The traffic is just going to become more and more intense, and I look forward to sitting in it. The future is bright. We're all going to, next time I do one of these, I'm going to hand out a shoebox full of cheap sunglasses. You got to wear shades. And I want to thank you very, very much. 4 years ago, I came to my first workflow technology conference. I said I was an emissary. Now, in the sense that a one-eyed man is a king in a kingdom of the blind, I'm a workflow expert in health. These are my blog. Chuck Webster is my main. I blog, a lot. HCBPM, healthcarebpm.com, is one place where I put kind of specific healthcare business process management success stories or stuff. EHRworkflow.com. I have a directory. I actually have like a little badge that you can stick on your website. Nobody's stuck it on their website yet. But the badge has Batman, POW hit, stars with POWHIT, and the words, people and organizations improving workflow with health information technology. Okay? And so when I find someone who I think is wearing the white hat, is improving healthcare workflow, I will write about them. And I will contact them on social media and say, why don't you stick my badge on your website? One of these days someone's going to do it. And then finally down here, ehr.biz, that's my custom vanity URL shortener. But if you go to there, you'll see almost 2,000 links that are use cases. If you are a BPM company or case management company, and you do something in healthcare and you have a use case or a story or success story, I'll bet I'm linking to it already. And if I haven't, please let me know. And the other thing is that by having 500,000 words on this stuff, if you search for healthcare workflow, BPM, EHR workflow, whatever, my stuff all comes up like on the first page of Google. And I'm proud. And that is it. And let's see, I think I just I nailed it time-wise. There's like 5 or 10 minutes left. And I was actually going to start off at the very beginning and say, insert joke about standing between you and a cocktail here. But I decided to wait till the end until I got a better sense of the audience. Anyway, 5 minutes for questions, and then I'll turn you loose, but I will be here at the cocktail hour, and I would love to talk shop. If you guys are already doing this stuff that I'm talking about, I'm raising consciousness. I'm saying if everybody gets together and speaks with the same voice, it's like a megaphone, Health IT will hear you because they are really, really receptive, in my humble opinion. Thank you very much.